I would like to thank you all for coming this evening. My name is Darren Gersh. I'm the president-elect of the Minnesota Academy of Family Physicians, and I practice family medicine in a town called Albany, Minnesota, which is just west of St. Cloud, a town of 2,500, of which I was just recently elected the mayor.
Yay!
We've invited our panelists tonight because we know that healthcare reform will influence how we deliver care to our patients. Both on the national level and the state level, big changes are being made, and we are only beginning to see how this impacts our practices. Let me briefly introduce our panelists, and when I say your name, would you please stand? We're excited to have one of the key players in the development and expansion of the patient-centered medical home to share his wisdom and enthusiasm with us, Dr. Paul Grundy. From the Minnesota Department of Health, Mr. Manny Munson-Regala. He will describe the development of Minnesota's health insurance exchange. Next, Dr. Doug Wood from the Mayo Clinic Health System. And he will share his extensive work on care integration. And to keep things interesting, we have Dr. Settgast, thank you, who will make the case that a single-payer system will reduce the cost of health care. To keep everything moving along and keeping us on track, we have asked Robert Christenson, who has moderated over 30 health-related panels, to serve as tonight's moderator. Once again, thank you for coming, and I'll turn it over to Mr. Christenson.
Well, you all have a program in front of you, and we're going to follow that program. The way we're going to work this roundtable, or this panel discussion, I'm used to doing roundtables, is that each of the speakers will provide about 10-12 minutes presentation of their remarks. And after they have completed their remarks, I will have some follow-up questions for them, as well as the other panelists will get an opportunity to ask them some questions. And then we'll move on to the next panelist. After all the panelists have made their remarks and all the questions are finished, then we'll open it up for questions from the audience. So let's begin then with Paul. And Paul will present his presentation. Thank you.
Thank you very much. Do I need to turn this on, or is it working fine?
It's on.
Super. So when I have the privilege of talking to a group of family physicians, I really appreciate the opportunity to do that, because fundamentally, you guys don't know how powerful you are. You're really humble, and you really don't understand, I don't think yet, fundamentally, that the reform that we're going to talk about today, the transformation of our delivery system, is fundamentally built on a set of principles that are about the kind of care that you're best trained to deliver. We're coming out of a world in which we rewarded folks who stored the most exotic knowledge in the head. We call them specialists, I call them partialists, because I think you also are specialists. You're specialists of family medicine, but you're really specialists of how to comprehensively manage care. So I refer to you guys as comprehensivists, and to people who do a part of the body as partialists. And it is so clear that there's no system of care delivery of value anywhere in the world that isn't built on that fundamental value system. And what do we value? What is it that we value about what you do, and what is it that I want to pay you to do as a buyer of care? What's the covenant conversation change that I want to have with the House of Primary Care about what it is as a buyer we want to buy? And it makes so much sense, right? Fundamentally, I want to buy a healing, trusting relationship and your ability to take and build on that healing, trusting relationship, an understanding of difficult diagnostic dilemmas. That's the strengths that you have. You know, when we survey our patients, when we ask who is the most trusted members of society, they will say their physician after their family. It's a very powerful and honored position that you're in. And the skills that you're going to have to now adapt, right, and learn, and probably should be learning, and agreed that that's what you needed to do in the future of family medicine when you looked at yourself a few years ago and asked yourselves what you should become, are the skills to be able to take a team and to manage a population, not an episode of care for somebody that walks through your door, but manage a population down to the individual level, right? In a system of care against a set of principles that are yours. I mean, you gave us the joint principles of the medical home, right? You told us what it was that would make sense to deliver. Now we have to help you in how we reform payment, in how we design the pay up against that, to be able to buy that in a way that you no longer have to be on a hamster wheel, you know, to just deliver episodes of care all day long without ever thinking about managing the population. You see, there are three huge driving changes that are happening, and they're irrespective of the law of reform. They're just what's happening globally. Unsustainable cost, right? That's one. Secondly, data. You see, we've never had the kind of data before that we're going to have now. I mean, tools like Watson that IBM building can sort through 300 million pages of structured and unstructured data, present it to you as clinical student support at the point of care in 0.3 microseconds. No longer is the system going to value the folks who can take the most esoteric data and store it in their head, because that data is going to be much more ubiquitous now. You know, no longer is a medical student going to have to be a data storage repository unit, right? Because that data is going to transform the way care is delivered. It's going to fundamentally break open the Flexner model. You know, no longer are you going to be master builders. No longer are you going to build a cathedral. You're going to be asked to manage a population with a healing, trusting relationship and your understanding of a difficult diagnostic dilemma with a team, right? With a plan. I mean, every patient's going to have a plan. The well to keep well, the acute to begin, or the chronics to begin to reduce risk factor in, and the acutes to make sure that care is managed. So we asked, the business community, 47 of the Fortune 100 got together. We asked the House of Primary Care for the joint principles. They gave them to us. And we asked all the healthcare plans to give us pilots. They did the pilots. The results were just phenomenal. You know, here in Minnesota, you had the first state that passed legislation around this. You have many of your practices that are transformed to this. Today, I have the privilege of going with your president and with your executive leadership and talking to the Minnesota Academy, the Minnesota Blue Cross Blue Shield Association, and they said they are all in now, right? They've been focusing on other things, and this month they're going to really focus on medical home. They're going to really focus on rural practices, and they're all in. They were extremely committed to that, so it gives me a great deal of optimism to build on the base that you already have. And with that, I think I'll stop, otherwise I'll talk all night.
I had the opportunity of looking at your TED Talk. Did you know you have a TED Talk?
I do.
Yes.
I have a TED Talk.
And one of the things that you focused on for physicians was on benefit redesign, on practices redesigned, and payments redesigned, that these would all be beneficial for primary care doctors. Could you elaborate a little bit on that, please?
Sure. If there are three things driving this, unsustainable cost, data, and communication changes that are occurring very rapidly. The three things that we really have to do, and we have to do all three, and you need to keep reminding people that all three of these have to happen, because you will be told by somebody that there's a silver bullet and we just pay money this way, that's all going to change, right? I mean, in order for us to be able to buy care of value, I mean, your practices are going to have to reform away from delivering an episode of care towards managing a population. That's a skill set that's very different. That's a psychology that's very different, right? You're going to have to act and think very differently. In order for that to be sustainable, we've got to reward you doing that by paying you to do that, by putting in place dials that begin to pay that to happen. And all over the country, we're seeing that happening, and we're seeing it happen very rapidly. So very few places are increasing fee-for-service anymore. They're paying with other dials in other ways, multiple ways. But most importantly, I think, or equally importantly, is that we have to prepare our patients to want to engage with you in a meaningful way and have skin in the game, right? So that we create reward systems that aren't a $20 co-deductible, but reward systems that incent them to exercise, right? Reward systems that incent them to take their medication. Reward systems, we do first dollar for primary care. You know, we reward folks helping train their families not to be obese. I mean, you know, there's mechanisms that you can put in place. I did a fantastic opportunity to look at a study that University of Michigan did for its employees, where they put a pedometer onto a cell phone and offered a reward system by which, if you use that pedometer, your benefits would go way, way down, right? But in addition to that, they understood the psychology of reminding patients how well they were doing. So every couple of weeks, they would get a reminder, you know, you did so much this week, it's really cool, you know, it would be even cooler if you did more. And what we found is at the end of a year, that 87% of those employees were still using that. We had reduced the number of risk factors in that population significantly. You know, and the folks that were the most opposed to doing that became our champions because we got them moving, right? And all of a sudden they said, thank God you got us moving, right? So, I mean, again, I think thinking through benefit design, one of the things that I saw a company do is use their cell phone and a little company called Blueprint for Health, which you can go online and you can look at the cost of care, right? You can look at whether it's average cost, you know, and so you design your benefits such that, you know, the healthcare delivery system that offers value, that's free. But if you go to a place where a delivery is twice as likely to give you a post-operative infection, and it's $4,000 more, you know, that's going to cost you $5,000 to go there out of pocket. So we're beginning to think about those kinds of benefit designs to incent that. So that's a long answer to that.
And